When a patient crashes in the trauma bay, the cognitive load on the attending physician spikes. You have seconds to process a massive influx of vitals, lab results, and patient history over the sound of alarms blaring. Rapid recall is mandatory. The USMLE and ABE simulate this pressure with dense clinical vignettes. You are hit with walls of text. A 45-year-old female presents with acute right upper quadrant pain, intermittent fever, and visible scleral icterus. It is an overwhelming amount of raw data designed to test your filtering capacity. For over a century, the traditional bedrock for filtering this data, both on written board exams and during surgical ward rounds, has been the eponymous surgical triad. Clinicians compress 3 distinct symptoms into a single named condition to speed up diagnosis. The flaw in this system is that naming a complex disease pattern after a dead 19th century surgeon provides zero mechanistic clues about the underlying pathophysiology. The name gives you the answer, but hides the mechanism. Rote memorization of arbitrary historical names fails under the severe cognitive stress of a real clinical emergency. If you lose the abstract link between the name and the symptoms, the diagnostic model collapses. To build a durable diagnostic framework, we must bypass the historical names. We are going to deconstruct 8 essential surgical triads by stripping away the eponyms and anchoring the symptoms directly to their logical anatomical zones. We will map these triads onto the physical structures they affect and lock them into your memory using targeted, custom mnemonics designed around the pathology, not the physician who discovered it. Mastering this anatomical mnemonic hybrid method bridges the gap between scoring highly on board exams and developing functional, rapid pattern recognition for actual clinical practice. This animated 3D diagram isolates our first anatomical zone of focus, the right upper quadrant, specifically the hepatobiliary system. The classic presentation for acute cholangitis is Charcot's triad. The underlying pathology is biliary stasis combined with a bacterial infection, turning a duct obstruction into a systemic emergency. Charcot defined this presentation with 3 specific components: intermittent fever, right upper quadrant pain, and intermittent jaundice. To lock this in anatomically, use the mnemonic FJP, representing fever, jaundice, and pain. Think of these as your frequently jaundiced patients. Only 20% of acute cholangitis patients present with the full triad. Relying solely on these symptoms to rule out infection leads to misdiagnoses in the vast majority of cases. If the bacterial load increases, the patient progresses into septic shock. Adding hypotension and an altered mental status to our FJP symptoms upgrades the diagnosis to Reynolds pentad. Transitioning from infection to physical trauma or iatrogenic injury brings us to Quink's triad, which defines hemobilia, bleeding into the biliary tract. Notice the pathology has shifted entirely to hemorrhage. Quink's triad shares components with Charcot's, presenting with jaundice and right upper quadrant pain, but the fever is replaced by an upper gastrointestinal hemorrhage. The mnemonic here is JAB, jaundice, ache, and bleeding. The physical bleeding into the duct is what separates this trauma pathology from the infectious pathology. On a multiple-choice board exam, differentiating these 2 right upper quadrant emergencies requires isolating that single variable. Identifying hemorrhage versus fever determines your diagnosis. We shift the anatomical focus downward from the biliary tree to the stomach to evaluate acute upper gastrointestinal emergencies. The dominant framework here is Borchards' triad, which serves as the hallmark of gastric volvulus. Gastric volvulus is a mechanical emergency where the stomach physically twists on its own axis, creating a closed-loop obstruction. A closed-loop obstruction is a blockage occurring at 2 distinct points, completely isolating a segment of the bowel or stomach, so nothing can enter or exit. Because of this physical rotation, the first component of Borchards is the mechanical inability to pass a nasogastric or NG tube into the stomach. The pathway is structurally blocked. The remaining 2 components are violent, non-productive vomiting, since the stomach contents have nowhere to go, and acute, severe epigastric pain. The mnemonic to apply here is NEV, never pass a tube, epigastric pain, and vomiting. Unlike systemic infections, Borchards defines a purely mechanical obstruction. It demands immediate surgical detortion, as medical management alone cannot untwist an organ. Continuing down the GI tract, this diagram zeroes in on the lower right abdomen, specifically the right iliac fossa. Murphy's triad maps the temporal progression of acute appendicitis. It tracks the evolution of the condition from onset to presentation. The timeline maps 3 components. It begins with vomiting, progresses to pyrexia, an elevated temperature, and culminates in focused right iliac fossa pain. The mnemonic for the patient's history is VIP, vomiting, iliac fossa pain, and pyrexia. While Murphy's triad maps the historical progression, Dulafoy's triad is its physical exam counterpart. It focuses entirely on localized tactile findings. Dulafoy's is composed of tenderness, guarding, and hypersensitivity of the skin, all localized at McBurney's point. McBurney's point is an anatomical landmark located exactly 1/3 of the distance from the anterior superior iliac spine to the navel, directly over the base of the appendix. The mnemonic for your physical exam is TGH, the guarding hurts. Murphy's triad clarifies the patient's subjective history, and Dulafoy's conforms the surgeon's objective physical exam. Together, they secure the appendicitis diagnosis. Stepping back from localized acute abdomens, this full body view allows us to analyze systemic and syndromic triads that span multiple organ systems. Saint's triad is the textbook illustration of Hickham's dictum. Hickham's dictum states that a patient can have as many diseases as they please, counteracting Occam's razor by acknowledging that multiple independent conditions often co-occur. Saint's triad consists of the simultaneous presence of gallstones, diverticulosis of the colon, and a diaphragmatic or hiatal hernia. While these occur in completely different systems, they share a hidden pathophysiological link. All 3 stem from a systemic weakness in tissue and a tendency toward herniation, most commonly observed in obese patients. The mnemonic mapping these disparate zones is GDH. Saints wear gold dark halos, representing gallstones, diverticulosis, and hernia. Transitioning to the Galatzia triad brings us to a systemic fibromatosis syndrome, characterized by the formation of benign, tumor-like nodules of fibrous connective tissue. Galatzia maps these fibrous deposits to 3 areas: Dupuytren's contracture in the hands, retroperitoneal fibrosis deep in the abdomen, and Peyronie's disease of the pelvis. Lock this in with the mnemonic PAD, Peyronie's, abdominal fibrosis, and Dupuytren's. Finally, we examine prune belly or Eagle-Barrett syndrome. This is a severe congenital mesodermal defect. The mesoderm is the middle cellular layer in an embryo that develops into muscle, bone, and connective tissue. Because the mesoderm fails to develop properly, the patient presents with 3 cascading structural failures: cryptorchidism, complete abdominal wall defects, and severe genitourinary tract defects. Map this defect with the mnemonic WUT, wall defect, undescendicestes, and tract defects. Mastering these systemic triads requires the clinician to stop looking at isolated organs. Look for underlying genetic or structural failures connecting disparate anatomical zones. This mapped matrix provides a primary filter for multiple choice boards. We have successfully anchored all 8 eponymous triads to physical anatomy. The hepatobiliary rules, Charcot's Phi-JP for infection, and Quink's JAB for dictator, Borchart's NEV for mechanical twisting. The appendiceal governors, Murphy's VIP mapping the history, and Dulafoy's TGH mapping the physical exam. While this mnemonic matrix is effective for test taking, clinical reality dictates a different standard. These groupings will help secure a passing board score, but in the trauma bay, a patient presenting with all 3 symptoms perfectly aligns with the textbook in only a fraction of cases. Atypical presentations are the rule. Use these anatomically mapped triads to quickly generate your differential diagnosis. Then, rely on your understanding of the underlying physiological failure to treat the patient in front of you, rather than the textbook eponym.